We do have a little bit of time. I kind of like to go through questions as we go. Gretchen's going to talk about the social work aspect of it, but before we move on, are there questions about the program, about Ms. Butler and her experience? Let's take some time to ask some questions. Sir?
From Anthem Blue Cross. Assuming I don't fall into the hole. But there, as you might imagine, there are no shortage of individuals and programs out in the community who claim to be able to deliver these types of services. And I'm curious, from your point, Dr. DeJong, what elements of structure and process should someone like my organization look for when evaluating an independence at home program?
Sure. So I think the first step is always to make sure you're focused on the right set of patients. In our case, it's folks who, and Independence at Home does this as well in their criteria. It's a set of folks who have severe chronic illness with real functional disability and a history of high-cost events. So the IH criteria are previous hospitalization, previous home care use, people who genuinely need intensive care at home. Because if you open up the gates to folks who are not that sick, then it's not worth the investment of the intensive resources. So you really have to focus on a patient population that's really 3 to 5% of most insurance panels. The second is the clinical team. If I had one key to our reasonable amount of success, it's finding an interdisciplinary team that's totally committed to doing this work. So that's docs, NPs, social workers, coordinator staff, and then building partnerships. That team drives the show. They're the captain of the ship 24/7, and having one point of contact, for the patients and families. Not a lot of intermediaries, honestly, not a lot of intermediary case managers and other kind of call centers, but the team that knows the patient and family and has their electronic health record available to them and can immediately respond in real time to get care to them in the home. That team then needs to be able to coordinate all the specialty care. We coordinate all subspecialists, procedures, transportation, home health, emergency room. We care for our patients in the hospital. So continuity to the hospital, that's a key element, that we take care of our patients into the hospital, we take care of them in the hospital, and we can take care of them as they leave the hospital. So managing the transitions in and out of the hospital has been a major reason why we've been able to be successful with cost reduction and preventing unnecessary high-cost events. So coordinate all the spokes of the wheel, all the kind of services that patient might need, including pharmacy, DME, and then hospice, near the end of life. We coordinate that as well. So a one-stop shop for kind of primary care and all that it entails for very frail elders. So there's the patient population, and then putting that team together. And our model is essentially one doc to 2 NPs, 2 social workers, 2 coordinators, kind of 8 or 9 staff, and an office nurse. So it's a team of about 8 or 10 people who care for about 300 patients. So it's an intensive, staff-intensive, financially intensive team that focuses on the most frail and disabled folks in the community. And then you have to execute. You have to be out there every day in the community, making house calls, being there immediately. Yesterday morning, one of our NPs kind of went out to see someone who had leg weakness. We made a diagnosis of possible TIA, got a brief ER evaluation, and that patient will go home after about 24 hours. So being available immediately. We don't make house calls all night long, but we were out there same day or next morning. Does that answer your question?
What infrastructure, so you mentioned electronic health records, any other elements that you think are critical for successful IH?
Good outcomes data collection, so being able to track the key, clinical things that are relevant to the patient and family, and then good kind of economic outcomes database so that you can track your success and really prove the value. That would be the other major one. But there were a few other questions, so we have time, sir?
So what I heard was things
I think the mic needs to be on.
So what I heard was that you had a wonderful experience and whatever. Our idea today is to try to figure out how to even make it a better experience for you and for others. So what we'd really like to hear about is how can either the policy change, how can the delivery system change, how can the social services that you receive change so that it can make it even a better experience for the next person that has to go through your life and your mother's life.
That's a very interesting question, and maybe it needs to provoke some more thought about it. But may I just say something first before I try to answer that? As my mother declined, I just recall, and I forgot to kind of mention, just preparing for her end of life. I remember in one setting in the hospital, Dr. DeYoung was just sharing, what are your mother's last wishes? What are the kinds of things that life support? We knew she expressed, but then the family came together and we had an opportunity to kind of talk through and have more knowledge of what are those things that we need to do to prepare ourselves as well as my mom's transitioning. And so I failed to mention that part. I just think that what you're doing and what you're saying right now, just the fact that you're here and listening and wanting to make it better, that's part of the cure right there, that you're already active and so really have your eyes on. And as long as you have the kind of thought process that Dr. DeYoung has and wanting to maximize caring for those who are unable to and who are not knowledgeable of all of the resources that are out here. I think that, a lot of times we just don't know what's available to help us through these things. So I hope that kind of gives you some inkling of what I was feeling.
Okay, sir.
Steve Council, Indiana
Hi, Steve.
University. Thanks so much for the wonderful presentation. I was interested in how you obtain the long-term services and supports in the home, aside from the medical team, and how that was coordinated with the family and the healthcare team. Was that through an aged and disabled waiver, for example, et cetera?
What a great question. This is a great segue, Steve. I'm going to actually ask Gretchen, who's totally immersed in that, to talk about that. And Gretchen, maybe you could just do the rest of your talk, just so we make sure you cover your, and then we'll have time for questions just before 9:30.
Sure. So there's one thing I wanted to touch on initially that everyone has brought up is the teamwork, which I think is really key to the success of our program. Yes, the patient is at the center of everything, but the caregivers are almost just as important as the patient. And I think what's really special about our program is that we recognize that and we really work closely with the caregivers. So on the team in our program, we have the patient, we have the caregiver, we have the physician, nurse practitioner, social worker, and then we also bring in the aide if there is one, neighbors, church members, family members. The team just isn't the medical professionals caring for the individual. It's whoever is involved with the care of that patient in the home. And I think that Ms. Humes was definitely an example of how everyone came together to care for her. The medical house call program, social worker initially got involved from the start, I believe, with Ms. Humes to help apply for the Medicaid waiver program. And through that program, she got a home health aide because Ms. Butler was struggling to care for her on her own, and the social worker was able to apply for the Medicaid waiver and bring in a home health aide. But the social work involvement did not end at that point. It was just not the application, and we stopped our involvement because, of course, the stressors and the needs did not end at that point. The social worker remained involved through the entire process throughout Ms. Humes' life. As a caregiver, it can be very, very stressful, and so emotional support is provided to the caregiver. We have a caregiver support group every month. We've hosted a caregiver conference. And so bringing in the social worker to help not only the patient, but also the caregiver has been key to a lot of these patients' lives. I think bridging the social needs and the medical needs is especially important for this population because sometimes there is a social need that can lead to a medical need or vice versa. And I think that's why having both parties work together towards the same goal is so important because sometimes the medical team will learn something or the social worker will learn something and they can work together to make sure that that patient can stay safely in their home. So I just wanted to touch on a little bit about what the social workers are doing in the home. Of course, we are connecting patients and family members with resources, how to get an aid in the home, if they need food assistance, housing assistance, insurance. A lot of people have questions about insurance because it's a very complicated system, as you all know. And the social workers are able to go in there and work collaboratively with the patients and caregivers. We provide a lot of emotional support to both the patients and the caregivers. We act as advocates throughout the community and within our own practice. So I think that gives a little bit of a summary about the social work role, and I think it shows in our numbers. Also, we have 4 physicians, 5 nurse practitioners, and 4 social workers. So not only do we say what we do, it shows in the number of social workers in our program that it is there is a need and that what we do is valued in the practice.
Great, Steve, does that answer your question?
Wait till it turns green, I found out. Yes, it does. I was going to follow up maybe on, part of my question was to lead to this is kind of a mobile PACE model, would you say, when you've got the Medicaid covering the home and community-based services for long-term care, they've got a case manager under the program, likely that then interfaces with the rest of the house calls team, but not all that comes with a typical PACE program. You might comment on that for the group.
Sure. I think clinically the mission and the approach is very similar to PACE. It's essentially PACE without walls, PACE without having to invest, honestly, in all the capital of the senior center and a lot of the prescribed kind of infrastructure that PACE requires, and it's available on a broader basis than PACE is because PACE is only for dual eligibles who are nursing home eligible, and this kind of program essentially expands the eligibility to folks of all types of Medicare in a mobile fashion, and it's not paid under capitated basis. It's right now a fee-for-service hybrid with shared savings. And that's kind of what Independence at Home and this national bill in the Senate right now is trying to expand. Another question, maybe right back there, David.
This goes back to Richard Frank's question first, so the critical elements of the success. So one of the things you didn't mention was the caregiver environment, the home environment. I work in Medicaid, so a lot of our high needs, high cost members do not have homes that look like this. And in fact, they burnt all their relationships in their life. They don't do relationships well. They're really difficult. You put a caregiver in the home, they don't get along. So there must be a point at which there must be a way in which you evaluate the home situation and say, this fits for us and this doesn't fit for us. And can you give us a sense of what the boundary, what that looks like? This feels, what this reminded me of in your description, Ms. Holmes, is the blue zones. There's certain things that, you just put the package together and everything works. And in this, the wonderful example you cite, everything was, in a certain sense, everything was there. Maslow's hierarchy was being met. But there's other people who don't have that opportunity. And so how far can you go in using this model in social situations that are chaotic or not as together?
Great question. So we use our model in DC in all levels of socioeconomic income, all levels of social, both great situations like with Ms. Butler and also ones that have no social supports. and our model works in all of those situations. It's much harder when there's no social supports, but we use our team to kind of try to solve those problems. We have exterminators on call. We have a whole variety of deep cleaning, social services. Gretchen and Ruth coordinate aides when there are no family. So we actually put all of these things in place, the delivery of mobile equipment, meds, social services, aides, and we have a nursing home placement rate of less than 3% per year. And this is with lowest of income folks as well as some middle and higher income folks. You can do this, and this is again in the geriatric population. The younger Medicaid population I think has unique challenges sometimes that I really can't speak about in as expert a way. But you can apply this model, and in fact this model helps stabilize those social, difficult situations in the elderly population. I'm going to stop there because Gretchen might be able to comment a little bit about how we address the chaos of difficult social situations. And we do in many cases.
That's the majority of my caseload. Well, I can give you a good example. Mr. F, he's paraplegic, he's bedbound, he lives alone. He was actually living in a nursing home, and we're fortunate in DC where we have a program to help people from the nursing home back into the community. And so with the support of that program, he got back into the community, and he had an aide from the Medicaid waiver program. He had burned all of his bridges. He has family. They visit him maybe once or twice a year. They send Christmas cards. They show up if he ends up in the hospital and there's a crisis situation. That's where the collaboration between the physician, the nurse practitioner, and the social worker really come together. I have a very close relationship with the home health aides. We rely on them. I text with them regularly. We really work together. Last week when I visited, there was a mouse problem, so called the exterminator. Really acting as the advocate for the patient and making sure that he has the help he needs in the home. There are many challenging situations, and Ms. Humes is very lucky that she had a very supportive environment, but a lot of the patients that we work with are not in that sort of ideal situation. It is possible. We do it daily, every day.
There's a ma'am in this front table.
How important is it to have a critical mass of patients in a particular geographic area for this model to work financially? Because clearly you've got both the time with the patient in the home, but then you've also got what Joanne Lynn has always called the windshield time. Is that an important part of the financial model in making this work, and how would you go about scaling it if it is?
Yeah, what a great question. So we are in the midst right now. MedStar Health has just a few months ago asked us to build a new team in Baltimore. And so we're building a new team in Baltimore around Good Sam, and right now we only have 30 patients. We hired the staff, and there's a startup cost of probably $500,000 to kind of start the team up. And in the first year or two, you're not going to break even until you get to a critical mass, probably of 150 to 200 patients is kind of what you need to get a team close to, 300 patients to get it to close to breaking even. So for that startup time of getting to 300 patients, you're going to have investment of capital. When we do our new teams, we pick 8 zip codes. So we have a driving radius of 20 to 25 minutes, and we're very strict about that. If we have to say no to folks who are in Potomac and Bethesda and Chevy Chase because we can't drive that far. So you need to have a small driving radius. And in rural areas, that can be 20 miles, but in urban areas, it's more like 4 or 5 miles. So you focus on 8 zip codes or so. You hire the core staff at the beginning, and then once you get to 150, 200 patients, you might hire the second nurse practitioner, and 300 to 350 patients is kind of a critical mass for one team. So we have time for 2 more questions. Far left.
Hi, I'm Lauren from the National Partnership for Women and Families. This is a bit of a 2-part for all the panelists. One is in terms of Jerry's earlier question about how can we make this better or scale it. Can you imagine a role for experienced caregivers who have been successful in this program to help coach teams that are just getting started? serving as advisor in terms of implementing it. So can you imagine a role for advisors in that way to catalyze implementation? And the second part to that for Veronica is, would you be willing to, I mean, it's not an ask, but it's hypothetical. Would you be willing to serve in that capacity?
So my answer to the first question is yes. I think experienced caregivers could be the best coaches for new teams. Ms. Butler?
Wow. I have that flavor for caregiving, or I just see such a need to support others who are walking that path, and so you know, that's interesting.
One more question in the far back, actually.
Waiting for it to turn green. Good morning. I'm Marianne Sterling from Connected Health Resources. More importantly, a family caregiver for multiple parents with dementia for 20 plus years. So I can definitely connect with our caregiver this morning on the panel. I want to express, as we're sitting here discussing this and we're talking about a piece of legislation on Capitol Hill that needs to pass before this can be perhaps a nationwide program. I actually belong to 2 Facebook communities that are geared toward Alzheimer's caregivers. About 6,000 people, caregivers belong to these 2 groups. And I just want to emphasize the utter desperation in this country of these caregivers who need this sort of program, and they need it yesterday. So again, coming from yet another desperate family caregiver, how can we how can we scale this? How can we do it quickly? And how can we get to those caregivers that so desperately need the program?
Yeah, great question. So one, I don't know if this is appropriate or not, but I would encourage you to put on your Facebook to ask those caregivers to tell their senators, right now is the key, to co-sponsor S3130 so this can be expanded nationwide. And it's a real simple ask. They just become co-sponsors. And then it's probably going to be reintroduced in January of 2017, where the House and Senate would both have to introduce it so that it could be expanded. And that, we can make house calls all over the country right now. What this bill would do would give a financial, sustainable model so that health systems, big health systems, would be willing to start this up all over the country. So once it passes, it would probably be another 18 months for CMS to do the regs so that it could be done nationwide, but the key is getting the payment system changed to reward this kind of care. I think we're done.
Perfect. I'd just like to thank the panel again